In this video, we will be covering mitral valve prolapse. Mitral valve prolapse is a type of heart valve disease in which the flaps, also called the leaflets or cusps, of the mitral valve become enlarged or stretched. These enlarged flaps bulge or prolapse into the left atrium as the heart contracts with each heartbeat. The function of the mitral valve is to control the flow of blood from the heart's left atrium to the left ventricle. A prolapsed mitral valve means that the valve's flaps do not always fit and close properly between each beat of the heart. The flaps enlarge and stretch inward toward the left atrium, sometimes snapping during systole, which may cause the valve to leak blood backward through the valve back to the left atrium. This condition is called mitral valve regurgitation. Mitral valve prolapse usually produces no symptoms. Rarely it progresses and can result in sudden death. Mitral valve prolapse usually occurs more frequently in women than in men. Other names to describe mitral valve prolapse include Barlow syndrome, billowing mitral valve syndrome, click murmur syndrome, flopping valve syndrome, mitral prolapse, myxomatous mitral valve disease. What causes mitral valve prolapse? The most common cause of mitral valve prolapse is abdominal stretched valve leaflets called myxomatous valve disease. A person can be born with the genetic risk of developing mitral valve prolapse. It also can be caused by other health problems such as some connective tissue diseases such as Marfan syndrome, Ehlers-Danlos syndrome, and Loeys-Dietz syndrome. These connective tissue disorders may cause myxomatous degeneration. These valve weaknesses or myxomatous degeneration causes mitral valve prolapse. It is not always clear what causes these tissue weaknesses. In some cases, families may pass it down to their biological children. What are the risk factors for mitral valve prolapse? Mitral valve prolapse affects people of all ages. Some people are born with mitral valve prolapse, including those who have connective tissue disorders. Rheumatic heart disease, scoliosis, and Graves' disease may also increase the risk of mitral valve prolapse. Mitral valve prolapse is more common in females, but males are more likely to develop severe mitral valve regurgitation, that is, blood leaking backward. Now, we will see the pathophysiology of mitral valve prolapse. Degenerative processes have two main histological phenotypes: diffuse myxomatous degeneration or Barlow's disease, or myxomatous mitral valve disease, with redundancy of anterior and posterior mitral leaflets and chordae, seen primarily in younger populations, and fibroelastic deficiency disease, seen primarily in older populations. It is not clear if these are two distinct disease processes or manifestations of a single disease. Mitral valve prolapse is a form of primary myxomatous degeneration of one or both mitral valve leaflets, which is a type of connective tissue changes. Myxomatous degeneration may involve valve leaflet abnormalities, chordae tendineae weakening and elongation, mitral annular dilation or thickened leaflet tissue, or mitral annular enlargement leading to segmental mitral leaflet prolapse. In mitral valve prolapse, the spongious layer of the mitral valve leaflets undergoes proliferation, and the cells in this layer multiply and expand. This proliferation is associated with the accumulation of deposit of mucopolysaccharides, which have a higher water content, which leads to an increase in the thickness and redundancy, that is called excess tissue, of the leaflets of the mitral valve. In short, Barlow's disease is characterized by thickened and diffusely redundant myxomatous leaflet tissue with disrupted collagen and elastin layers, leading to prolapse of most of the mitral valve leaflet segments, elongated chordae, and may eventually rupture. And annulus is typically direct and frequently separated from its normal myocardial support. Because of these alterations, the mitral valve no longer support each other during systole and fall into the left atrium. Other pathophysiological changes include fibroelastic deficiency, characterized by thin, translucent, and smooth leaflets, or deficiency in elastin, proteoglycan, and collagen with connective tissue deficiency. Fibroelastic deficiency is characterized by decreased connective tissue deficient in collagen, elastin, and proteoglycan, and also it is characterized by thin, smooth, translucent leaflets without excess tissue and only moderate annular dilation and thin, slightly elongated chordae. In contrast to Barlow's disease, patients with mitral regurgitation due to fibroelastic deficiency have a lack of connective tissue as a pathological mechanisms that triggers leaflets and chordal thinning and eventually chordal rupture. Fibroelastic deficiency results in thinning the leaflets and eventually leads to rupture. People with mitral valve prolapse, there is an increase in the content of type 3 collagen. It is a protein that provides structure and strength to tissues. At the same time, the elastin fibers, which provide elasticity to the tissue, become fragmented. This combination of changes contributes to the overall structural alterations observed in mitral valve prolapse. In mitral valve prolapse, the valve slips backward due to abnormal size or damage to mitral valve tissue. A portion of a mitral valve leaflet balloons back into the atrium during systole. Rarely, the ballooning stretches the leaflet to the point that the valve does not remain closed during systole, that is called ventricular contraction. Blood then regurgitates from the left ventricle back into the left atrium. Clinical manifestations of mitral valve prolapse. Signs and symptoms of mitral valve prolapse are due to the amount of blood leaking backward through the valve. Mitral prolapse symptoms can vary widely from one person to another. Many people with mitral valve prolapse doesn't have noticeable symptoms. Other people may have mild symptoms that develop gradually. Fatigue may occur regardless of the person's activity level and amount of rest or sleep. Difficulty breathing or shortness of breath, especially during exercise or when lying flat. A racing or irregular heartbeat may be present, that is called arrhythmia. Atrial or ventricular dysarrhythmias may produce sensation of palpitations, but palpitations have been reported while the heart has been beating normally. Another puzzling symptom is chest pain, which is often localized to the chest and may last for days. Anxiety may be a response to the symptoms experienced by the patient. However, some patients report anxiety as the only symptom. Some patients may experience dizziness or lightheadedness and syncope. Upon auscultation of an individual with mitral valve prolapse, a mild systolic click followed by a late systolic murmur heard best at the apex is common. To diagnose mitral valve prolapse, healthcare provider will usually do a physical exam and listen to the heart with a stethoscope. Often, the first and only sign of mitral valve prolapse is identified when a physical examination of the heart discloses an extra heart sound referred to as a mitral click. The systolic click is an early sign that a valve leaflet is ballooning into the left atrium. In addition to the mitral click, a murmur of mitral regurgitation may be heard if progressive valve leaflet stretching and regurgitation have occurred. If blood is leaking backward through the mitral valve, a whooshing sound also may be heard. Tests that may be done to help mitral valve prolapse and evaluate the heart include echocardiogram. An echocardiogram uses to create images of the heart in motion. Sometimes a transesophageal echocardiogram may be done to get more detailed images of the mitral valve. A standard echocardiogram, also called a transthoracic echocardiogram, can confirm a diagnosis of a mitral valve prolapse and determine its severity. Chest X-ray shows the condition of the heart and lungs. It can help show if the heart is enlarged. An electrocardiogram can detect irregular heart rhythms related to mitral valve disease. Exercise or stress test. These tests often involve walking on a treadmill or riding a stationary bike while the heart is monitored with ECG. Exercise tests help reveal how the heart responds to physical activity and whether mitral valve prolapse symptoms occur during exercise. Next test is cardiac catheterization. This test isn't often used to diagnose mitral valve prolapse, but it can be helpful if other tests haven't diagnosed the condition. A healthcare provider threads a thin tube through a blood vessel in the arm or groin to an artery in the heart and injects dye through the catheter. This makes the arteries in the heart chambers show up more clearly on an X-ray. Now we will see the management. The medical management. Medical management is directed at controlling symptoms. Many people with mitral valve prolapse don't need treatment. If patient has a mild form, the provider may simply monitor patient with a regular checkup. Medications may be needed to treat irregular heartbeats or other complications of mitral valve prolapse. The medications are beta blockers. These drugs relax blood vessels and slow the heartbeat, which reduces blood pressure. And also, it helps manage symptoms like dizziness or heart palpitations. Chest pain that does not respond to nitrates may respond to calcium channel blockers or beta blockers. Diuretics or water pills. These medicines remove salt and water through urine, reducing the blood pressure. Next drug of choice is antiarrhythmic drugs. Antiarrhythmic medications may be used to help control irregular heart rhythms. If dysarrhythmias are documented and cause symptoms, the patient is advised to eliminate caffeine and alcohol from the diet and stop smoking. Next drug is anticoagulants. If mitral valve disease is causing an irregular heartbeat called atrial fibrillation, the healthcare provider may recommend blood thinning drugs to prevent blood clots. Atrial fibrillation increases the risk of blood clots and strokes. If patient had mitral valve replacement with a mechanical valve, the blood thinners are needed for life. If patient has a history of stroke, patients may need to take anticoagulant drugs. Next drug is antibiotics. Antibiotics are usually necessary for someone with mitral prolapse, but if patient has had mitral valve replacement, healthcare provider may recommend taking antibiotics before dental procedures to prevent a heart infection called infective endocarditis. Surgery or a transcatheter procedure may be the best mitral valve prolapse treatment for some people. The most effective approach depends on many individual factors. Most people with mitral valve prolapse don't need surgery, but surgery may be recommended if mitral valve prolapse causes severe mitral regurgitation, whether or not have symptoms. Now we will see the surgical procedures used to treat mitral valve prolapse. Mitral valve repair. Mitral valve repair is preferred because it saves the existing valve. Surgeon repairs the valve to help it function as it should. A repair allows to keep the valve and avoid some risk and complications of valve replacement. During mitral valve repair surgery, the surgeon might remove excess tissue from the prolapsed valve so the flaps can close tightly. The surgeon may also replace the cords that support the valve. Next procedure is mitral valve replacement. For some people, getting a new valve is the best or only option. If mitral valve repair isn't possible, the valve may be replaced. During mitral valve replacement surgery, a surgeon removes the mitral valve and replaces it with a mechanical valve or a biological valve. The biological valve is made from cow, pig, or human heart tissue. Next procedure is a transcatheter mitral valve replacement. Working with a catheter through a blood vessel, this option uses a smaller incision than open procedures.